in the borough of Southwark in South London. So I'll be talking about our experience in Southwark, and then Helen and Eleanor from Barnet will be sharing their experience of therapy assessments during this time as well, to hopefully give you a sort of holistic overview across paediatrics and therapies. So a couple of announcements we need to ask of you first. The first thing is that this session is being recorded. So it's advised to keep your cameras off, not because we don't want to see your lovely faces, but because I think that helps the connection, and it is being recorded. So if you have questions, please use the chat function. And what we'll do is, after mine and Helen and Eleanor's presentations, we'll review the questions and be able to answer some of those, hopefully. And also a request, if you can, please, to put your role and where you are from into the chat box, so that can be looked at as well later. Okay, so I'm going to share my screen. Hopefully you can see that now. Dan, please speak up if there's a problem.
Yeah, no, I can see it fine. So
perfect. Okay, so first of all, it's just to share our experience from a community paediatric perspective. Obviously, as community paediatricians, we're very involved in developmental assessments of children, neurodevelopmental assessments, and providing advice for children who need additional support in school. So just to set the context really of our service, we're based across Southwark and Lambeth, which are two inner city boroughs in South London. We're quite large services. We have a high referral rate to community paediatric service, and in Southwark Borough we have over 2,300 children with EHCPs currently, and we are lucky that we have maintained an EHCP medical assessment clinic for children going through that process, either children who we haven't met before, for whatever reason, or children who haven't been seen in the recent past, so we can give updated advice, and we run those once or twice a week depending on demand for that. We were also very fortunate at the beginning of the COVID lockdown that we had a couple of things already in place. One was that our service had undergone an agile working programme in the latter half of 2019, so that all staff who are working in community children's services, so that's across community paediatrics, across therapies, health visiting, school nursing, specialist nursing, and the admin staff, had all been enabled with laptops or tablets that had camera and video, which is obviously essential if you want to carry out video assessment of children and patients. So that gave us remote access not only to the electronic health records, but also to our emails and the service folders to be able to carry out the assessments that we needed to. So at the beginning of the COVID-19 lockdown, obviously adaptation had to be made, and most of the doctors in our team and many of the other teams in community children's services moved to working remotely, which was primarily at home, with just a small number of doctors remaining on site on any given day by rota. So almost all of our community paediatric clinics were then running remotely. And the only children we were seeing face-to-face at our child development centre were those children having child protection medical assessments, or the very vulnerable children who we felt needed urgent assessment, and we weren't able to assess adequately via a virtual assessment. The platform that we've been using for this has been Attend Anywhere, NHS platform. And again, we were lucky that we already had this in pilot use. Some of our clinicians were trying it out to see how we might be able to use it in community paediatric services. And of course, we thought with running developmental clinics, we thought it probably wasn't really suited to video clinic, but as I'll describe, we have had success with it. But as with any new technology, there needs to be some skilling up. So that was skilling up not only of the clinicians using it, but the admin staff, really importantly, because they're the ones who kind of train the patients and families in how to use it, how to get on there. So a lot of skilling up. That particular platform needs Google Chrome browser at the provider end, and with any of these video consultations, you need a good internet connection at the patient end, and that's crucial, and we'll talk about that in a little bit more detail. We have found with remote working and working at home that it has been pretty much crucial to have an extra monitor screen to be able to work comfortably from home. The laptops and tablets are fantastic, but they have small screens, and to be able to run a video clinic and make notes and access notes or patient notes at the same time, you really do need that extra monitor screen. So that is something to be taken into consideration in terms of long-term implementation of this way of working. We've also found that a headset not only helps with sound quality, but it's an important thing for the child and family know that whatever they're saying is not being heard by the rest of the clinician's household when the clinician is clearly working at home. So we were able to start that really early on and crack on with clinics, and we evaluated those first 6 weeks of clinics, during which time we'd run something like near to 150 paediatric consultations this way, a lot of them general developmental clinics, but also looked after children's clinics, the EHCP medical assessment clinics, and multidisciplinary neurodisability clinics where we had paediatrician and various therapists and sometimes interpreters as well. And that can be done on this on the Attend Anywhere platform. And our experience is now extended to almost double that number. And so what I'm going to describe also will reflect some of the sort of evolving challenges and modifications we've made along the way. So this kind of describes what the doctors felt about the video consultations during those first consultations that we analysed. In green are the things that we thought went well with the consultations, but of course some drawbacks as well in red. We did feel overall we were able to make helpful observations and discussions with the child and family and make plans and use developmental tools, but there were definite difficulties, and a lot of that was to do with technological problems. And we've tried to address some of those issues as we've gone along. The patients and families gave really nice informal feedback that they were very thankful actually to be in contact with us during this time. Some have been on waiting lists for 2-3 months already, and of course when COVID struck they felt they were going to be left in the ether, and to be able to make contact with them and have a discussion they were really grateful for. So we have been able to use developmental tools actually during these consultations using the screen share option. This at the bottom is showing the use of the Ravens developmental tool to be able to look at non-verbal and verbal development. That's used for primary school age children. It's very easy to use a range of screening questionnaires around behaviours, possible ADHD, possible autism. So questionnaires are easy to administer over this format. And we've started using some of the aspects of the Griffiths 3 developmental scales, which are being developed to be able to be used virtually as well. That's a developmental tool for the younger children, the 0 to 6-year-olds. But as we've gone along, I mean, it has become very apparent that there are areas of challenge that really we do need to be thinking carefully about, and should not go unnoted really. So one of the big challenges is with technological setup for the patients and families. So we know that digital poverty is a problem and that is causing inequalities, and the very families that we want to be in contact with most are those that may be under-resourced and may not have access to either the equipment or the data or Wi-Fi connection to be able to run a video consultation. It uses a lot of data. If you don't have Wi-Fi and you're using your 3G, 4G data, using a video consultation will go through a lot of it, and we've had heartbreaking cases where actually the one video consultation has used up all of the parents' data for that month. And of course, that is something that we need to be thinking really carefully about. We need to find a solution to that, because we can't let that happen if we're going to be using this way of working into the future. Another thing we've noticed over these weeks and months of working this way, at the beginning we were all very enthusiastic that it was great we were able to be in touch with patients and families, but actually it's really exhausting. It's very tiring to carry out the sort of assessments we carry out, which are often an hour or an hour and 15 minutes long, gathering really sensitive information. And doing that over a video where you're trying to read body language, read how the family's interpreting what you're talking about. If there's any delay in transmission, it's very difficult to keep that flow going, and you need a different level of concentration really. So this is something that does need to be taken into account again as we think towards the longer term future. And it is very apparent that this kind of video assessment, although it's great for some purposes and definitely some children can have an initial assessment this way, it's very clear that you can't complete a whole neurodevelopmental assessment wholly using virtual assessment, and you do need to see the child face to face for that sort of experienced assessment of the child's interaction and neurodevelopmental profile. So autism diagnostic assessments are one assessment that has had to remain on hold whilst we try and find a solution to running autism diagnostic assessments. You simply can't do that over a video. That would not be fair or just, and you can't run an autism assessment in a standardized way if you're using PPE, face masks, etc., where the child cannot see your facial expression and may be distracted by what's on your face. So we need to find a solution to that, and work is ongoing in that area. So this is just a flow chart of how we have gone about setting up and delivering video consultations. So as I say, it's important that when the appointment is booked, the admin staff can train the client how to use it. When you're consulting, it's beneficial to have a platform where you can add other clinicians in, so other team members or interpreters. You can carry out some assessment and then be able to provide a report that's hopefully helpful. These are some tips that are sort of widely available in relation to how you should carry out video assessments and make video consulting useful. And we found it helpful to have a bank of online resources for families that are easily accessible, that we can very quickly email out to them whilst they're not able to access some of the face-to-face resources that they would usually be able to access. So I'm going to move on to Helen and Eleanor's talk, and we'll take questions at the end if you put those into the chat box. Thank you.
Hi everyone, I'm Helen Tanyan and I'm the TCO in Enfield, but I also manage the booking services, and I have Eleanor Lesser with me, who's one of our clinical leads in speech language, and I thought it would be really helpful for Eleanor to share some of the work that they did around, adapting COVID in delivering the statutory.
Oh, I'm sorry, Helen, the sound quality is really poor again. Could you move a little bit closer to your mic, perhaps?
Okay, do I need to repeat or can I carry on?
No, that's much better. Yeah, just couldn't. It sounded like you were underwater slightly. So.
Okay, sorry. Yeah. Okay, so I'll just make sure I'm really next to you. I'm functioning a very old laptop, so that might be the reason why. So I'm going to start with what we did in Enfield. So in terms of Enfield, we were fully operational. Our services were fully operational. So pre-pandemic, all of our work was primarily face-to-face, and I'm sure that was the same for everyone else. So the staff had to adapt very quickly to new technologies. It was quite a swift turnaround between face-to-face, telephone and digital working. So what we designed initially to think about this was really just a very simple priority rating, level 1 to 3, so that we could respond to escalations and knew which children need to be seen as a priority, and making sure that all the caseload was stratified according to priority levels, including the referrals that were being triaged and screened during COVID. So level 1 really is for those children with fluctuating and deteriorating health conditions, post-trauma, or where there's active health input in terms of child protection plans. Also, all our children on CHC, continuing healthcare packages, admission avoidance, and discharge planning around hospital to home support. Medium priority was really all those children that required to be monitored in terms of preventing clinical deteriorations, and where medically their needs were being medically compromised. We also categorised all our children on EHCP provision, as well as the advice, the statutory advice referrals that were coming in as level 2. So those children were continuing to be seen in spite of staff being redeployed to inpatient areas and rehab areas. We made sure that the percentage of staff that we needed to deliver level 1 and level 2, seeing those children, were still retained within our service. Level 3 was really those children on low clinical priority, where they were deemed to be able to be safely managed whilst the support was being delayed. But we continued to monitor any rising risks within that population of children. So I'm going to now pass you over to Eleanor in detail about what happened within the speech language service in terms of delivering the EHC provision and the statutory advice.
Hi, I'm Eleanor. As Helen said, I'm one of our clinical leads. Enfield is a very diverse North London borough, and our specialist services are made up of occupational therapy, physiotherapy, dietetics, specialist nursing and speech and language services, all of whom generally provide statutory advice where appropriate. So during the academic year 18-19, Enfield agreed approximately 635 statutory assessments, and you can see that the predominant numbers of statutory advice of 393 that year was provided by speech and language, with much fewer being provided by the other specialist services. This year so far, there have been fewer statutory assessments agreed, partly because we've had a real slowdown in the applications. But again, you can see that the bulk of the advice has been provided by speech and language services. So we have a continuous and ongoing requirement for providing an assessment. So the changes to that assessment process, once schools closed and we realised this was going to happen, we realised we were going to have to move to a telephone and conferencing platform. So senior team wrote some guidance about the best way to carry out the calls, which included a script of frequently asked questions. We provided the script largely so that people could build their confidence. And there it is on one of the subsequent slides. And so you'll be able to get a copy of that when you get a copy of them. Therapists also spoke to some of the young people, often with a further call arranged, and it was mostly the older people. So most of our information was gained from parents, with some of it from the young people where possible. And we've also changed our report format to reflect the fact that we know that we're going to have to do more to add to this information once schools reopen. So the questions were really designed to help the parents reflect on their children's language, and that has been very helpful. We've emailed some of the questions home to parents so that they could actually have a look at them in advance, and the parents fed back that we were able to mediate some of the language needs associated with behaviour difficulties, where parents thought it was mainly the behaviour. Through those negotiated discussions, we were able to help them think through the fact that actually it might be a primary language difficulty. And parents were given that opportunity to go through the questions with an interpreter before the speech and language therapist came online at times, so that they could think through their answers with an interpreter, and we found that was extremely successful. This is the verbal and the sent in advance by email version. I'm not going to go through it, it's long, and you can have a look at that in your own time. Helen's going to now talk quickly about the OT.
So just very quickly to say about OT. OT always see children with their families as the initial contact. And so the goals and the outcomes are all co-produced with the parents and the young people and the children. And then in the second phase, they would then carry out a school or nursery visit if that's identified as being necessary with the parent, or to complete the statutory advice or monitor the HCP intervention. So due to COVID, the initial face-to-face session was then replaced with telephone or video calls with parents, and where possible with the young person as well. And similar to SLT, what we were finding were these were taking an awful long time. So a face-to-face appointment, which could be about an hour, was now taking at least 2.5 hours through digital means and telephone. So this would be split between 2 appointments and time allocated, as it could. As you know, what we were finding initially was, as Jess said, it's incredibly tiring for both the staff and the parents particularly. OTs also began inviting schools and nurseries into the teleconference or in the same video call, so they would be jointly working through a digital platform. Parents would email relevant evidence like drawings or handwriting samples if possible. Staff would also complete a observational video with the children engaged in different activities at home, and that would be relevant to the specific assessment. Although what I would say is that had its own challenges, as it was really hard to observe things like handwriting through a video link. Staff are at the early stages of developing coaching approaches, and that is something that we really need to work on, and also mapping technology to therapy through the virtual platform. And what staff across all of the services were saying is it's so much easier when they've already got an established relationship with the parent, rather than doing this as a first time with a new parent. The outcome from the project over March to May has shown that there's a high level of parental satisfaction, and the parents reported feeling well supported. But obviously it is far easier when one has already got an established relationship with the family. I'm going to pass you over on to Eleanor again.
Okay, so the challenges to working with these families have really been that not everyone in our team had a phone initially. So they were using their own phones and blocking the number if they could. But that meant that the parents weren't actually opening and answering the calls because it was an unlisted number. So we were able to get hold of a range of new phones for them. So, and we started to pre-warn them that there was going to be a call by sending a message which didn't give any of their information, but which was able to warn them that we were going to be calling. And we found that jumped very quickly to a better answering rate. Therapists initially were all worried that this was going to be a really difficult way of working. And actually, once they'd done it once, they were all fine. And we've been giving a lot more supervision. So our supervision's upped from between was once every 6 weeks or so. We're seeing everybody for supervision between every 3 and 4 weeks now. We found that the parents were sometimes angry because they'd been waiting, or because they didn't like the system, or they didn't think there was much point with the telephone call. And we found that just by doing some more proactive listening, it was very helpful, and that the parents have actually felt very much more listened to and have been much happier with the outcomes of those calls. Access to translators, well, our service has been mostly a school-based service. So we've been relying in schools on using a teaching assistant to translate for us, which we've now realised is completely not ideal. So we've been working very closely with the language shop with much better success. We've been getting more information from parents, and they've been saying things to us that we probably wouldn't have gained from them in the past. It does take a really long time, but we've just had to absorb that within our planning. And as everyone else has said, it is really quite draining. Our report structure has had to change. So we've added an introduction to the report, which just talks about the fact that we're complying with the statutory process, but that the report is not going to have as much information as it would normally do. So previously, pre-COVID, you can see we're showing a little bit of an example here. We had a small amount of information from the parents. Parents were always offered an opportunity to talk to us at school, but frequently they didn't actually attend those appointments or had very little to say because they were just listening to our assessments. So now you can see that we're getting a lot more information from the parent. We've put in green what the differences are in the information we're getting in pre and post-COVID. So pre-COVID, the strengths was largely assessment-led. Post-COVID, you can see in green all of that information is the information that the parents have provided, which has been really positive. Areas of difficulty, you can see pre-COVID, very few difficulties were provided by the parents. Post-COVID in green, you can see there's a lot more. And the little bit in purple there is the parents' largest anxiety, which we've then used when we're setting outcomes. As you can see, we've put an outcome in purple, which is the parents' largest concern. We have a standard outcome for everybody, which is around the school being able to understand the students' needs once everybody's returned, which will be our assessment. But actually, we are able to put in the parents' concern with lots of ideas of how they can actually carry that out at home, which would also be applicable at school. Gains in our therapist confidence, gains in the, therapists who've never used a translator service before have been now quite ably using translators, and we're able to give these skills to a broader range of therapists because more of our team are carrying out the assessments than usual. The quality of the co-produced information is significantly different. We'd worried it would be poor. It's actually been very, very good, and we've had some great feedback because parents feel much more listened to and heard, and that active listening has really helped parents to see and understand the process. So you can see we've had some specific feedback from parents. They've really enjoyed that support, and they've actually found it really helpful to talk through their child in a way they perhaps haven't managed to in the past. We want to carry some things forward from this assessment process. The quality is helpful from the parents. The risk is that it's doubling the amount of time we would normally take to assess a child. And we also wanted to move forward with using independent language translators because it's a better quality. But again, the risk there is that it costs more. I'm going to hand you over to Helen now, who's going to talk about the physio input.
Okay, so in terms of enteral physiotherapy, the service covers 0 to 19, and we deliver to musculoskeletal, children with musculoskeletal issues, referrals that come in, as well as neurodisability. So with the physios, some of the worries initially were really around missing the red flags. So those symptoms that could indicate conditions that required urgent medical attention or were kind of life-threatening. But helpfully, NHSE issued some guidance in April, mid-April, I think it was, on, MSK under 16. So that was about supporting physios in screening for potential pathologies, looking for new and worsening symptoms, and also escalating or persistent pain. There was also this issue of, physios were really concerned about not picking up any of these early flags quickly enough, concerns about misunderstanding between therapist and family, without the hands-on and the tactile assessment, in terms of aiding that clinical decision-making, not being able to complete a full assessment, and worrying about the quality of the intervention that was being delivered digitally, and whether parental satisfaction was going to be high, and would they be valuing the service through digital means. So the second slide is really around those. The second slide is an example of the priority triangle that was there before, but at a more granular level in relation to physios, how everyone really thought through stratifying their caseloads, and which children would continue to benefit from face-to-face intervention, and which children and families could be seen through digital means. So in terms of those top tips around deploying virtual models of working, parents sent in videos and photographs of their children via secure email to aid the assessment and decision making. We also really upped the use of digital platforms like Attend Anywhere, and that whole digital working was cascaded and developed very quickly within a few weeks. Again, like SLT, all the teams increased staff supervision, peer working for case discussions, and online resources were really put together quite quickly. There was also clear guidance for face-to-face visits, so children were not put at clinical risk. So stratifying cases on face-to-face and non-face-to-face working. A guide was put together for parents prior to video sessions on how to set up and what to expect, and the administrators began to take that as part of their role, additional role. As the referral numbers were going down, we had that spare capacity from our admin staff to support. There was also advice to parents on activities that will needed to be observed, so the session is fully prepared for prior to the assessment, with assessment pro formas and scripts being developed for both the staff and the parents. Assessments were taking over potentially 2.5 to 3 hours. It was fairly much longer through digital platforms compared to face-to-face. So the assessments were split into sessions, with a telephone call initially to gain a good history, followed by a video consultation to focus purely on the more objective assessment and observations, which was particularly useful for younger children. And then there was joint decision making with the parent based on those clinical risks and benefits to determine whether the next session would be, again, a digital platform or face-to-face. So in terms of what the feedback was, most cases actually benefited from digital intervention, and that seemed to mitigate against the numbers needed for face-to-face contact. There was increased flexibility and time saving for families and clinicians. The families really their feedback was really around the fact that it wasn't a 9-to-5 service, and they had that level of choice around when the sessions would happen. So we worked. Some families preferred evening appointments, digital appointments, as opposed to during the day. Both parents and the staff felt that they were addressing the concerns much sooner, and parents felt that made a huge difference in terms of anxiety levels. And the staff were really surprised at how effective their observation skills were. They felt they developed another sense very, very quickly, and that was a surprise. Some of the challenges were around designing and developing full assessments and giving advice, and that took much longer than the face-to-face. I think going forward, it is a combination of modalities around telehealth and face-to-face. So in terms of the intervention and those challenges around it being much harder to fully assess and developing those coaching skills in terms of handling skills for the parents through digital medium or virtual mediums, this has now been mitigated by really having a criteria for which cohorts of children would absolutely benefit from a face-to-face rather than a digital platform, or needed face-to-face as well as virtual support. Some families have just not been able to access video consultations like Jess was talking about. So taking into account socio-economic factors is really important. So making sure that in the first screen that we're absolutely giving parents the choice, the parental choice, having a face-to-face or having a digital intervention. We still need to develop impact measures around evidencing progress and the evidence of the benefits. You know, I think a lot of work still needs to happen around the research, proactive research into the values and the risks of digital and telephone consultations, working with PAs and coaching skills that are important in terms of making the approach incredibly valuable and having a benefit. And a lot more work around mapping technology to interventions also needs to happen. And I think what we've learned is that working remotely hasn't actually compromised care to that extent that people were really concerned about. You know, and we felt reassured that we'd taken the time to develop alternative methods and retaining those alternative methods as part of going forward. But also many parents still prefer face-to-face, and this is really evidenced with their feedback. And so we need to develop confidence and win hearts and minds really around the use of digital technology and making sure that children are still receiving face-to-face assessments, and using a blended model is the way forward. And I think for our sakes, kind of the learning for us is face-to-face appointment will always be offered. And in fact, we've started doing our face-to-face interventions as of the beginning of June. So our clinics are already open with appropriate infection control in place. And that provides clinical assurance to both the clinician and the family. The default position is always that we are going to be using digital and telephone going forward. So remote technology does have its place, but not at the detriment of face-to-face, I would say. Okay, so that's me.
Great, thanks very much. If anybody has questions, do you want to pop them in the chat box, and then I'll kind of read them out and we can get responses?
I think we can mention, sorry, this is Jess again. So one of the questions in the previous workshop had been, are we going to continue virtual assessments after the COVID pandemic has run its course? So just to mention on that front that it is something that we are thinking of using to some extent into the longer term, keeping aspects of it. Within the paediatric service, we will be using it for our general paediatric clinics, as general developmental clinics, as a sort of first stage, and then triaging which children need face-to-face assessment after that. So I think that's just, it was an interesting question to ask, and an important one, obviously, when we're thinking about planning the future. So there are some aspects that we will be keeping, but definitely some clinics we will be going back to primarily face-to-face, and the big ones on that front are the autism assessment clinics and the neurodisability clinics, those where we need hands-on to assess the child's physical disability. So just in case people are interested in that bit of information.
Great, thank you. And some feedback there from Laura saying it's been really helpful to hear back about physio successes. Now, Anne Hardman saying, oh, that's disappeared.
He was asking about whether or not we think that our EHCP assessment is up to a level that we're happy with. No, we've got a lot of information, but we need to still carry out some assessment within the speech and language service in particular. So our target will be, once schools are open, that we will complement those assessments with a school visit in order to complete some direct face-to-face assessment and observation, because clearly you can't get a full picture of a child's speech and language without seeing them in the context of their educational placement.
From a paediatric perspective on that front, most of the children we've seen virtually for EHCP medical clinics, we haven't had to see again actually it's obviously it's a different part of the assessment, but from a paediatric perspective, most of the children we've been able to gather enough advice to be able to put together an EHCP medical report. But of course, yeah, I think for the therapies that's much more challenging, and there's definitely some children that we are going to have to see again at some point to be able to give updated advice.
I mean, one of the things, turning this on its head, I think one of the things that we've learned is the kind of the communication and the relationship with parents, I think, is the gain from this whole process. And we didn't realise the gap that we had within our service until we tested this out. So I think it's going to have to be very difficult conversations with commissioners around how much time this is all taking, because obviously the quality has gone up. We haven't got a full assessment, but what we've found is that the quality is vastly different to what it was pre-COVID because of the intensive interactions that we're having with families as opposed to schools. So that we don't want to lose that. And it's about, you know, now how do we carry that forward within the same capacity that we're funded for? So it's going to be an interesting conversation to take forward.
Great, thanks everyone. And if there aren't any other questions, can I just remind people, if Marie's just very kindly posted a link for the evaluation for the day in the chat. It'd be really helpful. It only takes a couple of minutes if everyone could complete that, because it really helps us kind of show our funders that everyone's appreciating what we're doing and helps us put on more events like this. So if you could, does anybody have any more questions in the last couple of minutes, or are we all done? No, great. Okay, well, thanks very much, everybody. That was really helpful, and thanks for spending time with us on this very hot afternoon in front of your screens. And yeah, go and make yourself a nice, well-earned cold drink of some variety.
Thank you, Dan, and thank you everybody for attending and listening.
Right, thanks very much.
All right.
Thank you.